How do I design a behavioral plan that the patient's brain is likely to sustain? The first clinical task is to regulate expectation. If expectation is unrealistic, disappointment becomes highly likely. And if disappointment is repeated, motivation often deteriorates. So, one of the earliest interventions is expectation calibration. This means begin explicit. Progress may be slow. There may be fluctuations. The body may resist. The plateau is not necessarily failure. This is not pessimism, it's protective realism. Second, we need to reduce the effort reward mismatch. Lifestyle interventions often require high effort while offering delayed reward. That's a difficult neurobiological bargain. So rather than prescribing intensity too early, it's often more effectively to prescribe sustainability. A 10-minute walk most days may be more useful than an unrealistic gym schedule that collapses within a week. Small achievable actions reduce resistance and allow reinforcement to build. Third, we should reinforce behavior, not only outcomes. If we focus exclusively on the scale, the HbA1c, or the lipid profile, we risk ignoring the behavioral progress that precedes those outcomes. It's clinically useful to acknowledge consistency. You came back, you continued after a difficult week, you reduced sugary drinks, you became more structured, you persisted. These are not merely encouraging phrases, they are reinforcement signals. Fourth, we should make reward visible in the present. If reinforcement is always distant, behavior becomes more difficult to sustain. So it's important to help patients notice immediate benefits where possible. Improved sleep, more stable energy, a sense of control, less guilt, improved routine, a modest mood improvement, or greater physical ease. When patients perceive that something is already changing, the behavior becomes more sustainable. Fifth, we should replace behaviors, not simply remove them. Many behaviors that clinicians try to eliminate are serving a function. They relieve stress, provide comfort, reduce emptiness, or regulate emotions. So, if we simply remove them without offering alternatives, relapse becomes more likely. A more useful principle is this: do not remove a source of reward or relief without helping the patient establish another. Sixth, we should work with both cortical and limbic systems. Much clinical advice is aimed at the cortex. It's logical, rational, and future-oriented, but behavior is often driven by systems that respond to immediate emotional meaning and reward. Therefore, explanation alone is often insufficient. The plan must also feel manageable, meaningful, and rewarding enough for the patient to sustain. Seventh, identity matters. One of the most stable forms of behavior change is identity-based rather than outcome-based. If the patient sees themselves only as someone chasing a number, motivation can collapse when the number stalls. But if the patient begins to see themselves as someone who is becoming more consistent, more informed, and more capable of caring for their body, the behavior often becomes more durable. Finally, shame should be reduced wherever possible. Shame is not a reliable engine of sustainable change. In fact, it often undermines it. When patients move from self-blame to understanding, engagement often improved. That shift matters because when we reduce shame, regulate expectations, and align interventions with how behavior is actually learned, patients often become more capable of sustaining change.